Well, welcome back, everyone. I hope you had a great morning session in the presentations. I know I certainly did in the common data model presentation. I hope we also had some time to get some lunch and perhaps even visited some of the lunch rooms that we had set up so you could engage with each other a little bit. Well, this is now a very special part of the Research Forum agenda, and I'm delighted to introduce our keynote speaker for the 2024 Research Forum. Dr. Tara Kiran is a senior adjunct scientist with ICS in the Primary Care and Health Systems Research Program. She is the Fidani Chair in Improvement and Innovation at the University of Toronto and Vice Chair of Quality and Innovation at the Department of Family and Community Medicine. She's also a practicing family doctor and a renowned primary care researcher, just an all-around good person. Dr. Kiran investigates how changes in the healthcare system impact patients, particularly the most vulnerable. In her research and practice, she develops and tests solutions to make healthcare more inclusive and more effective. In 2022, Dr. Kiran launched OurCare, a national initiative to engage the public in co-creating the blueprint for a stronger, more equitable primary care system in Canada. She practices family medicine at the St. Michael's Hospital Academic Family Health Team and is a scientist at the MAP Center for Urban Health Solutions at St. Michael's. So now over to you, Tara.
Thanks so much, Michael. It's really a pleasure to be here, especially because I think it's 15 years ago or so that I started my research career at ICES. And I think many of you may know me as, doing a lot of primary care research, trying to understand the impact of reforms on quality of care. Because, actually, I graduated from medical school back in 2002. And even at that time, we thought primary care was in crisis. I remember in my graduating class, it was a decidedly unpopular specialty to choose. It was, I think, the one year that the University of Toronto family medicine residency actually went unmatched. We knew that there were too many people in the province who actually didn't have a family doctor, and we knew we were in a crisis and needed to do something differently. And so actually there were a number of reforms that were introduced in Ontario. And, I spent a lot of my career trying to evaluate them, also trying to, leverage the new tools to make care better. So fast forward now to 2024, this is me in my practice at St. Mike's, in the clinic that I work at. I'm really lucky to work in a team-based setting. I actually, am paid through something called blended capitation, which gives me a little bit more flexibility to spend more time with patients. I still really love what I do. I love the privilege of being able to get to know patients over time in the context of their family and their communities. I can see the value of primary care in my practice, me being that touchstone for patients to help them to integrate that complex medical and social decision-making that they have to do, and now helping them to navigate through that system. But it's a real shame that in 2024, there are actually, more than 2.3 million people in Ontario who don't have access to primary care or family doctor, who don't have access to what I call the front door of the healthcare system. And when you don't have access to that front door, everything else falls apart. Over my career, I've been really lucky to try and be part of tables where actually we think about how we can do better. And what I noticed over the years is usually at those tables, there are people like myself, there are researchers, clinicians, policy wonks, people in government, but usually there's a voice that's missing. The voice of the very people that the system is designed to serve, patients and the public. And so that's how OurCare was born. I felt like it was time for us to have a fresh perspective. And I'd had the privilege of working with patients in different ways over the last few years and really seen how impactful it can be in helping us to see things differently, to actually see how we're maybe not seeing things in the way that's most important. And in a way, it actually brings people together because, I've also witnessed over my career many different siloed interests. Yes, we all want to make the healthcare system better, but often we're stuck in our own ways. And having that patient public voice helping us to align together in a single vision, I felt would be incredibly helpful in reorienting our system and the stakeholders in it. So we launched OurCare now over a couple of years ago. which was really this 16-month-long endeavor to we heard from nearly 10,000 people who collectively spent nearly 10,000 hours. And we wanted to hear not just their experiences, but their perspectives on how we can do better when it comes to primary care. So I'm looking forward to telling you more about what we did and what we learned today. But just to start off, to say that I'm just putting forward some of my own disclosures, none of which pose a conflict for today. And also just wanted to say a thank you to our funders and acknowledge them. They weren't involved in directing the work or influencing my presentation today, but thank you to Health Canada, the Maxwell Foundation, and Staples Canada, who did fund this initiative. This initiative was also a really big lift in the sense that it was a collaboration across the country with so many incredible partners. In essence, this was a partnership between myself and a number of primary care leaders, together with people who have expertise in public engagement. And our partner, Peter McLeod, and the Mass LVP team, they really put forward, for years, this vision that ordinary people can solve complex problems if we give them the space and facilitation and time to do so. So that's really the essence behind OurCare. So let me take you back to the start. That was in the fall of 2022. We conducted a national survey where we heard from more than 9,000 people across the country. And we made our results publicly available. You can go to data.ourcare.ca and actually play with the data yourself. I think one of the key findings at that time was really that far too many people don't have a family doctor, that varies across the country, and that even those that do struggle to get timely access. But we also asked them about, how they wanted to do things differently, and we heard how open people were to just doing things in different ways, whether that meant team-based care, whether that meant geographic kind of solutions. They were interested in doing things differently if it meant that more people could have access. We followed up from the national survey with something that we call provincial priority panels, and we did 5 of these. In essence, we brought together randomly selected members of the public. They didn't know each other, they were strangers to start, and we educated them about the primary care system. We did this in 5 provinces, and I'm just going to show you a photo here of our gathering in Ontario. So these are 35 randomly selected people from Ontario. They are actually from a pool of, I think, 1,250 people who volunteered for this opportunity. We actually asked 40 hours of them in Ontario, and it's pretty remarkable to me that 1,250 people who responded to our survey or saw the opportunity elsewhere put up their hand and said, yeah, I want to spend 40 hours of my time in conversation to improve our healthcare system. And then from those 1,250, we randomly selected 35 to roughly represent the demographics of Ontario. And you can see the 8 characteristics through which we randomly selected them. There was some overrepresentation of equity deserving groups because we were mindful throughout this project that was a perspective we wanted to ensure was there. And so you can see in Ontario as an example, we really brought together what we think about as Ontario in a room. They came from all across the province. And then of course we did this not just in Ontario, but that was in February of last year, but in May of last year, we gathered another panel in Quebec. And following that in June in British Columbia, in July in Nova Scotia, and in October, our last panel in Manitoba. And this one was special in that, our advisor committee in Manitoba gave us the advice that they wanted us to actually overrepresent the Indigenous population on the panel, because they recognized that people who were Indigenous in Manitoba were really those who were facing the most barriers to care and the worst health outcomes. And so almost 1/3 of the participating panelists in Manitoba were Indigenous, and many of the recommendations were very specific to improving Indigenous health. We knew, though, that even with our efforts to ensure diversity within the priority panels and our large outreach with the national survey, that we were likely missing some voices, really important voices, because access to primary care is an issue for many people, but it's more of an issue actually for people who are marginalized. And we wanted to ensure marginalized communities' voices were really heard. And to do that, we had 10 community roundtables. They were each 1 day in length. Basically, we asked people about their experiences, good and bad, in the healthcare system. And we did tell them about what the priority panelists had recommended, and they could say, what they thought, resonated with them, what they might disagree with, and other additional ideas for change that they may have. And you can see here that a really key part of our success in being able to do this was really rested on our partnerships with community organizations across the country. And it allowed us to have roundtables with members of the Indigenous population, Black communities, many different newcomer groups, the LGBTQ community, people with disabilities as an example. In Ontario, we had 2 roundtables. One was in partnership with Well Living House and the Indigenous Primary Healthcare Council, and focused on the needs of First Nation, Inuit, and Métis living in urban and related homelands. And the second was with the Black Physicians Association of Ontario and the Durham and Taibu Community Health Centres. And it was just in Durham, not too far away from the center of Toronto, but a very diverse place where, and this is the photo actually of that folks in that roundtable. And really interesting because there was a lot of intersectionalities that came together. Yes, these were members of the Black community, many from the African continent, but many were newcomers as well, and many actually were Francophone. So there were many different intersecting identities that played out into their recommendations as an example. And in this specific roundtable, I think it was simultaneously translated in 3 languages, and we had other roundtables where it was simultaneously translated in up to 5. So we took great care to try and make it an inclusive environment so that we could really hear the voices of those who are often left behind and not heard. Following each of these stages, we issued reports. And so you can find all 16 reports on our website. I wanted to emphasize that the priority panel reports are actually written by members of the public themselves. So this is not our interpretation of what they said. They actually spend the time during the 30, 40 hours together writing their initial report. At the end of that time, they actually present it to policymakers, and then they have a process in the weeks following where they can kind of group edit it on a Google Doc, and then we help to pull it together in a formatted way. But these are really their words and their voice, and I urge you to go on our website and take a look. But what's been remarkable to me through this journey is really seeing over and over again this, what I find to be awe-inspiring, to be honest. People who are complete strangers, treating each other with utmost respect, listening very carefully, not just to the speakers, but to the experiences of the people in the room. Having these respectful conversations, and despite so much diversity, including diversity in viewpoints, coming together with a really strong consensus of what it is that we need to do to move primary care forward. And we saw this play out time and time again in each of the priority panels and roundtables. And it's pretty remarkable that in a time of incredible polarization in the world, that when we brought people together to converse respectfully, there was just so much agreement. And what's also incredible is that if we look across all of the conversations we had, there are certainly consistent themes that kept coming up again and again. And so we summarize all of what we heard in our final report, which we released at the end of February. And I'm excited to share more with you about what it is that we found, and something that we're calling the OurCare standard, and hearing your thoughts about how we can move it forward. But before I do that, I wanted to share with you the actual voices of the people that we spoke with. I wanted you to meet them, to hear why it is that they volunteered, and what some of the things are that they took away from the experience. So I'm going to turn it over to our team, who's going to share a video.
I volunteered to be a part of the OurCare panel Because of my own health issues, I struggled between having a doctor, losing a doctor, and being resorted to walk-in clinic, which has not been able to help me in my own healthcare needs.
And I wanted to be able to provide our voice to the people who make policies in order to try and make it a better experience for other people going forward.
And knowing that my generation is going to be inheriting this very important system, I feel like it's my duty as a citizen to do my best to build the system and improve it so that it can be sustainable for the long term.
Ce que je trouvais qu'on a en commun, c'est chacune de ces personnes-là qui sont ici présentes, de ces collègues, ils sont ici pour le même but de se faire entendre et d'apporter d'amélioration.
I'm not as alone as I maybe thought I was. Everybody, even though you have different backgrounds or different histories or different needs, all really at the end of the day wants the same thing, which is a healthcare system that works for everybody.
Whoa, okay, I'm not the only one, you know, and to realize that a lot of people have the same goals in mind in regards to healthcare and how they want to improve healthcare.
I felt like I was a pretty good navigator of our healthcare system and found out there's so much I don't know. And so if I don't know as someone who thinks I know quite a bit and has used it a lot, how much do other people not know?
To bring 36 people together with varied backgrounds from various parts of the province to get together and literally in less than 2 full days of working, we're developing strong, actionable recommendations.
Because I know personally I'll take, whatever I've learned over the last 4 days back to my own, town and area and try and continue the work that I've come to realize as being important here in the group.
I have learned way more about how the healthcare system in this province works than I ever thought I could learn this quickly. I've also learned, though, that the answers to the current crisis are probably in the room with us. We just need to get the right people to listen.
So I think you can see from that video, the diversity of folks we spoke with, but also just some of the common themes, that for them, their struggles with primary care, that their desire to make the system better for generations to come. This idea that when they participated, they really realized that they weren't alone, that there were so many other people in the same boat that they were in. And that they learned so much and they valued learning about the system. And even people who thought they knew a lot realized that there was more to learn. What I also hear there is the hopefulness, this hopefulness of the coming together, of the empowerment of the citizen voice. As you can imagine, every time I went to all of the 5 priority panel closings, and every time I think the term that came to mind was moral beauty. This idea that people who are so different can come together in a very special way to speak from one voice. And so when they did come together, what is it that they said? We introduce in our report something we call the OurCare standard. 6 simple statements that summarize what every person in Canada should expect from the primary care system. I think of it as a distillation of everything we heard through the 16 months and the 10,000 hours and nearly 10,000 people. And I'm going to share today with you these 6 statements, and we'll walk through them one at a time. I think this is a way for us to think about a vision forward. It's also a way for us to think about measuring different types of reforms and thinking, are these the reforms that actually help to put us in a direction that is consistent with how people want. So to start, the first standard, everyone has a relationship with a primary care clinician who works with other health professionals in a publicly funded team. It calls out the idea that there does need to be a relationship, ideally with one person, but that person, let's say a family doctor, nurse practitioner, primary clinician, should be working together with teams. There was consistency across our consultations on expansion of team-based care And everybody really felt strongly that we needed to ensure that this was all publicly funded. People really cared not just about their own primary care access, but those of their loved ones, those of their neighbors and their communities. They wanted to ensure that everybody had access. The second standard was that everyone receives ongoing care from the primary care team and can access them in a timely way. So it's that balance between ongoing and timely care. And timely care to our panelists and roundtable participants meant care also that was after hours, so in the evenings and weekends. They saw a role for virtual care, so virtual care should be integrated with in-person care, they said. It should be publicly owned and accountable, and ideally used in a way that actually advances equity goals. And in particular, they wanted to see virtual care enhance access in rural and remote communities. The third standard is actually one that we added in after we basically showed our draft standards to some of our participants. And they said, hold on, I don't think that there's enough focus here on wellness, because ultimately they wanted to see a system that was focused on wellness and not sickness. And so the third standard really speaks to primary care being connected to community and social services, so to be able to address social determinants of health that collectively then support physical, mental, and social well-being. The fourth standard was really born through hearing about consistent frustrations that people had about accessing their own record. I have to say, when we first started this process, I don't think this was on my radar as one of the things that would come up on a primary care engagement, but it came up again and again very early in all of our consultations, especially in the context of many people not having a care provider. And so, in that context of not having primary care, it's so important to have access to your own records to be able to navigate the system and advocate for yourself. And so the fourth standard is that everyone should have access to their health records online and be able to share it with their clinicians and their caregivers. The fifth standard has a lot in it. Everyone receives culturally safe care that meets their needs from clinicians that represent the diversity of the communities they serve. So this means care that's free of racism and discrimination. And unfortunately, in many of our roundtable consultations and in our priority panel discussions, there were many instances of racism and discrimination that were brought to the fore, sometimes very painful ones to hear. And there were consistent recommendations that we need to address that in a multitude of ways, including with our training of professionals and also in our current contexts. When we say meet the needs of patients, it's a broad statement, but it relates to the idea that sometimes when people had access to primary care, there were limits to what their doctor may or may not do for them. They might say, oh, I don't deal with addictions, or no, I don't deal with gender affirming care. And the idea is that if you have primary care in a team-based setting, that team should be able to meet all the needs. And that includes the full range of medical and psychosocial needs. It also means that care needs to be delivered in a way that's accessible, so that we have ability for people who don't speak English or French or the dominant language in the region to be able to access care, that care is physically accessible in a clinic. People felt that one way to move towards culturally safe care was actually to have clinicians that more closely reflect the diversity of the communities that they serve. And there were a few different ways in which they thought this could happen. Of course, one is to do a better job recruiting and training people from underserved communities and equity deserving communities in Canada. That includes even just thinking about high school and encouraging people even in high school and rural and Indigenous communities to think about a career in medicine or a health profession. But it also included the acceleration of the training of foreign trained professionals into our system. There was consistent agreement around that in all of our priority panels and roundtables. The last standard in many ways to me is the most important and really speaks to the need for us to reorient the system to serve patients and communities. So it talks about that everyone receives care from a primary care system that is accountable to the communities it serves. So what does that mean? It means that we need to be transparent. We need to have public reporting on how the primary care system is doing, Interestingly, when we looked across the country to see, what provinces were reporting on their primary care system, the only province where we could find current primary care data actually was New Brunswick. The rest, there really wasn't any consistent reporting in this area. We need to ensure that there's transparency around investments. People wanted to see not just what the investments were, what the impact of those investments were, and have that all be transparent. And they talked about the role of research for those who are on the call and researchers in being able to support that. Accountability also meant, though, that patients were involved in everything from setting what those performance measures should be, to governing local team clinics, to kind of other policy decisions at provincial and national levels. It meant that patients and the public were more educated and empowered. As you heard, people loved the education and the sessions that we provided, and they wanted everybody to have access to that, and all of the reports called on that. And lastly, I think it also puts forward this idea that government should be accountable to funding services, primary care services in communities commensurate to the need. So seems like a lot. From my presentations to date, I'd say I think the standards resonate with people out there. And the hard part, though, is taking them to say, okay, what next? How can we actually put them into practice and design a patient-centered vision for primary care? I will say that I think there are tangible actions, some of which we name in the report, that can help us to get there. For me, one of the most important pieces is for us to put out the goal very clearly that we're going to design for 100% attachment. So it's not enough to go from 75% to 80 or 80% to 85% of people having primary care. We really have to set the goal at 100% and design the system around that. Because if we just go with incremental improvement, we will never get to the goal of 100%. I think getting to 100% requires a paradigm shift in thinking, and that's why we need to set that goal. We do need to invest more in primary care, and I'll speak more about that. We do need to scale up teams, and we can see some of that happening. We need to be very thoughtful about how it's done. There are ways for us to ensure that patients actually get access to their records. Right now, I have access to more records of my patients than they do themselves. That shouldn't be the case. And then, of course, there's many different kind of very concrete suggestions to address equity. But as we do this, I think it's really important for us to also take a step back and think about, where is it that we are right now as a starting point? And as I mentioned, data from our survey found that, more than 1 in 5 people, or more than 1 in 5 adults, I should say, doesn't have access to primary care. And based on our survey, we would translate that to more than 6.5 million people in Canada. And what's really remarkable is the incredible variation that there is across the country, with some regions like Atlantic Canada and Quebec, that being a stat being as high as almost 1 in 3. And even when we hold still and hold constant other factors, what we can see is that actually there's a lot of variation by province, even after we adjust for things like newcomer status or age or gender of the people who responded to the survey. And so Ontario and Quebec, Ontario and the Prairies, kind of have the best attachment rates. And we know from living in Ontario, most of us, that actually we're doing pretty badly here. So you can only imagine how terrible it is in these other provinces. But it also just really speaks to this idea that we have a lot that we can learn from each other, and just how driven, things like primary care access are by provincial policies. Similarly, we have a long way to go to try and scaling up team-based care. This is some data from our own survey. I should say that actually there's, when we think about trying to measure up to the standard, there's actually a dearth of data that actually measures on some elements of the standard. So this is data from our survey around team access to teams. And what we can see is maybe a third of people have access to a nurse practitioner or a nurse, but it's less than 15% when it comes to a social worker, pharmacist, or dietitian. And again, if it varies considerably by province. So if you're in Quebec and Ontario, much more likely to have access to teams than you are in other parts of the country. And of course, we know even on Ontario, 25% of people have access to teams, but it's not logically distributed. And this is the great work of my colleague, Rick Glazer, using the ICS data that really showed how, there was an inverse care law with areas that are most in need having the least number of teams. So what we have in Canada right now, unfortunately, is a situation of haves and have-nots. Some people who have fantastic access to a team. Maybe, for example, some of the patients I think that we serve at the clinic where I work and I'm lucky to work. And then we have others who have access to a primary care clinician that doesn't work in a team, but they still have a family doctor that they can see. And then we have others who basically have nothing. And it's an incredibly unfair situation. And I think the onus is on all of us to think about how it is that we can rectify it. And understanding that, there may be some things that some of us who do have to give up in order for the have-nots to have more in the short term. But hopefully in a long-term kind of basis, we can bring all of us up. And, so what do we need to do that? I'm sure you're thinking, oh, she's just calling for more money, expansion of teams. Well, it is important to note, though, that, when we did some work comparing Canada to countries that have really good primary care access, what we found is actually Canada had the lowest percent of health spending that was public, 70% compared to, 80, 85% in many of these other countries. And what we also could see is that Canada spends less of their total health budget on primary care. And this just shows, the average of 22 OECD. It shows about 22 OECD countries and how Canada compares. But it's not just about money. I do think that there are other things that we can do. And I also don't want people in the audience to leave feeling, hopeless that we can't move this forward. Because if there's anything that I think the OurCare process brought me, it's hope. This idea that there is power in the collective and that we all have an opportunity to actually understand our own agency and the power that we might have. I think some of that power relates to, our voice as ordinary citizens, members of the public. When you go onto our website, you'll see that we have some interactive components. You can measure how your care measures up to the OurCare standard. But importantly, we actually have made it really easy for you to send a letter to your elected representatives to say, here, primary care in Canada is not good enough. The OurCare standard puts forward a vision and we need to adopt it. So, what I hope is that, this is just the beginning of a bigger movement. And I know many of you on the call here, you have power that goes actually beyond even just being a citizen, but you have power maybe as an educator, as a clinician leader, as a researcher. And I hope that we can think about, how is it that we can each use our own power to kind of move forward a positive vision for change that's centered on what patients in the public want to see. I want to end off here with this quote from the Manitoba panel, something that they wrote together in this report. Together, we feel that the current primary healthcare system honors the system more than it honors and cares for the people it should serve. We truly hope this report is the vehicle through which our voices and ideas for improvement are heard and meaningfully acted upon by decision makers. This panel has modeled the respect, compassion, active listening, and relationship building that needs to be reflected in the primary care system. So thank you so much for listening today, and I look forward to answering some of your questions. And of course, check out ourcare.ca to learn more.
Terrific. Thank you so much, Tara. That was a fantastic presentation, and congratulations on that extensive public and patient engagement exercise across Canada. I don't know that there's been anything that can possibly rival that, certainly not in primary care. So just a reminder to the audience, if you have questions, to put them in the Q&A tab. And maybe I'll just start, Tara, by asking you a question. So were there, when you're talking about strengthening the primary care system, was there discussion about different ways of delivering primary care? So you touched a little bit on virtual care, but I'm wondering about, for example, the role of nurse practitioners versus a primary care physician, or even, we're in the era of ChatGPT and technology. And was there discussion about whether there is or isn't a role for technology in enhancing or contributing to primary care delivery in Canada?
Yeah, great question. And I will say that there was really strong support for integrating nurse practitioners into the primary care system. We saw that very clearly in our survey. So we asked a question about, would you be willing to see a nurse practitioner for most of your care, except for when a family doctor was needed? And I think it was like either 90 or 95% of people said yes, they would. And similarly, we asked a question on the survey related to, would you be comfortable seeing another member of the team if your family doctor recommended it? And again, 90% of people said yes, we would. And so people are really open to different ways of doing things. People were even open to this idea that, okay, you'd be not attached necessarily to seeing the same doctor over and over again, but you would belong to a clinic and they would have access to your records. And, you would try and see the same doctor, but you might not be able to. And, not as many people said that they were into that, maybe about 70-75%, but people were open. And particularly people, of course, who don't have a family doctor were even more open, but both groups were. And we saw that reflected in the discussions that we had. And that's why there was just like a really big consensus that, everyone needs to be attached to a primary care clinician who's part of a team. And what was interesting, though, is that there is variation across the country. So in Ontario, when we had the panels, you would have people who belonged to a wonderful family health team or community health center, and people who didn't, or maybe didn't have access to primary care. And those stories would be shared, and people would be like, oh, wow, I didn't realize that was there. Or somebody would be like, oh, I didn't know that what I had was special. And so that, organically kind of came out as an important recommendation. In other provinces, though, in like British Columbia, very few people had actually experienced team-based care. But we did expose people to that idea and brought in teams, and people felt it was important if we were going to move forward with teams, that it be done in a way that's actually community governed. So one of the models that we saw be called out specifically across all our panels were examples of community governed teams. So in Quebec, the panel called out CLSCs. In Manitoba, they called out access centers, and in BC, they called out CHCs. And what's in common with all of those models are that they are community governed. I will also say that in Ontario and BC, they very specifically kind of put forward this analogy with the public school system. So, you move to a new neighborhood and you have a young child who needs to go to school. You don't have to think twice about whether they're going to get into the education system. We take it as a given that it's a right. And similarly, we should be thinking about primary care like that. And so, in fact, Ontario went so far to say, teams should be mandated to take on anyone in their catchment area, and that there should be some kind of flexibility for patient choice. And they kind of laid out what some of those ways in which they could maintain patient choice would be. But I think it was pretty visionary and bold for them to put that forward. And in other panels where they heard that kind of solution from their from their speakers, like in BC, I think it also really resonated. So yeah, people are really open to doing things differently, Michael. Oh, and you asked me about AI. There wasn't a lot of discussion about AI, actually, and that being, people want someone that can care for them. And even with virtual care, it was important that they had the option for in-person care. It wasn't enough to just have standalone.
Okay, terrific. All right, so I'll take some questions from the chat here. You're speaking to lots of researchers out there. So question says, how can you integrate clinical research into primary care? Do you see the need to make strategies to give everyone access to clinical research?
Mm-hmm. Yeah, it's a great question. I think my colleagues at the University of Toronto and across Ontario have banded together to pull together a number of practice-based research networks. So we have about, I think, 7 practice-based research networks across the province. They all make up collectively something called Poplar, and I think they're actually a wonderful vehicle through which to try and get primary care more involved in clinical research. A shout out to my colleague Andrew Pinto, who's leading, for example, a trial on Paxlovid and COVID, and primary care is the perfect place in which that can be done. So I do think there's a role for primary care in clinical research.
Great. We've got about 4 minutes left, so hopefully we can get a couple more questions in. Here's one that says, thank you so much, Dr. Kiran. Curious about whether there's a plan for the OurCare team to stay connected with the public members as the initiative moves into the stages of action and implementation? And if so, what does that look like?
Yeah, such a wonderful question. I mean, it's something that we've been thinking about. How do we continue to keep people engaged? In some provinces, like in Nova Scotia, they actually self-organized and they have their own Facebook group and the email chain that, you know, I get to be part of sometimes, and they send me emails. In others, they weren't as proactive in doing that. Sometimes, though, it was because they just didn't have the foresight. There was like this intense weekend, and then they didn't realize, oh, I need to get other people's phone numbers or emails. And so what is our role to help to facilitate those connections? We're trying, we in many cases have introduced them to members of government, for example, who want to engage with them. We have a newsletter that we provide and engage them through. But we're actually also thinking about how do we develop an alumni network to actually, because these are all people who've really spent a lot of time learning and have a lot of knowledge and are very activated. Another thing we did was actually run an advocacy workshop for people who are interested, so helping to support them to have meetings with their elected representatives or speak to the media.
Great. Okay. Here's another question regarding intersectionality. Have you explored the data looking at intersectionality? For example, what proportion of racialized women of a certain age living in a rural area have a family doctor versus others?
Yeah, really great question. I think we would probably have to have an even better sample size to get down to the kind of granular intersectionality that you just raised. I think it's a really important question. I would say, you know, one of the weaknesses of our survey is I feel like it underrepresented people who are newcomers, people who are racialized, people who are Indigenous, and you know that's why we made deliberate efforts in those other stages to have their voices heard. I know Statistics Canada is doing a massive survey on primary care, and I'm hoping that that kind of analysis can be done through their sampling.
All right, so last question here for you is a good one. Great work on patient engagement and highlighting the voice of racialized communities. I wonder how you and your team are getting primary care providers engaged in implementing the standards and what barriers they might have in moving this work forward.
Such a good question. I think, you know, at the most basic level, it's about sharing this work with primary care, my primary care colleagues, and I've had some wonderful opportunities to do that through conference presentations over the last year, also invitations at meetings and collaborations with medical associations and family physician organizations across the country, in each of the provinces. I think many of the leaders do see the value in the OurCare standard. I think for me, you know, one of the critical components that as clinicians we need to reflect on is that number 6 of being accountable to the communities we serve. I think primary care has become really hard and people are feeling very demoralized right now. And there's some good reasons why they're feeling demoralized. You know, it's a profession that often doesn't get the respect, including, you know, whether that's money or kudos that it deserves. But I also think that if we focus too much inward into what also is not working, it's not helpful for ourselves or for the people we're serving. And I think what I took away from this process is the value of us reorienting the system to serve community. And to me, that's the gem that I want my colleagues to take away, is how can we reorient everything that we're doing in that light. And I think we have lots of work to do to help to move the profession to be even more there. I will just say a small anecdote that, you know, somebody who's been in practice for almost 40 years reached out to me and he said, you know, I remember when I started, that was really the ethos of what we did, was just like serving the community. And I feel, and he shared how he felt like we moved away from that. And it's been to the detriment of our communities and to ourselves. And that this was a reminder that we do need to come back to it. And perhaps this is one of the pieces that can help us to then save ourselves as a profession and I think support our communities, of course.
All right, well, Tara, thank you so much. That's all the time we have. The chat is full of questions that we didn't have time to get to, indicating the interest in your talk. That was a great way to mark the keynote plenary session of the Research Forum. And so thanks again for participating with us today. So now we're going to move straight into the first afternoon panel session, which is moderated by ICS Chief Science Officer, Dr. Astrid Gutman. That panel will be followed by a 15-minute break, and then we'll meet back when I moderate our final panel. So come with me and let's join Astrid in the first panel now.